السلام عليكم. As already said in the previous presentations with Dr. Dua and Dr. Catherine, I will continue. Gastric cancer is the third most widespread cancer-related death worldwide. It generally affects men higher than women. Various factors, including Helicobacter pylori and bad diabetic habits, smoking, give rise to gastric cancer. Radical resection, including adequate lymphadenectomy, offer the only chance for permanent control. Accurate staging and evaluation of treatment response are crucial for appropriate management. Usually diagnosed at advanced stage, that's because it mimics benign lesions. Diagnosis depends on the patient history, physical examination, endoscopy. It's essential for the diagnosis of the disease. Endoscopic ultrasound, CT, and MRI are used for initial evaluation of gastric cancer. And what's the role of PET-CT? National Cancer Comprehensive Network Clinical Guidelines version 2 2022 recommend the use of FDG PET-CT for evaluation of gastric cancer from skull base to the mid-thigh if clinically indicated. But PET-CT has some limitation in gastric cancer. First of all, confusion with the physiological gastric uptake. Next one, some gastric histologies are not PET-avid. Spatial resolution limits the ability to distinguish between primary tumor and compartment 1 or 2 lymph nodes. Histologic classification of gastric cancer showed that poorly cohesive signature cancer and poorly cohesive, not otherwise specified cancer, mucinous adenocarcinoma, according to WHO classification, show low PET avidity. That's signature carcinoma and mucinous carcinoma, according to Meng's classification, undifferentiated carcinoma, and diffuse carcinoma, according to Laurent classification. Next, sometimes it's difficult to differentiate between compartment 1 and compartment 2 lymph node station in gastric cancer based on PET. And the third, in spite of this limitation, PET might be useful for evaluation of therapy response before surgery and determination of occult metastatic tumor, but it's not for cancer screening program because it has lower sensitivity than endoscopy. This study involved 60 patients with biopsy-proven gastric carcinoma analyzed retrospectively in the period between April 2020 and December 2022. Inclusion criteria: patient with histologically proven gastric cancer with no age restriction, no gender predilections. Exclusion criteria: uncontrolled diabetes, contrast hypersensitivity, and patient with impaired renal function. We used the routine PET scan. Patients are prepared, instructed to fast for at least 4 hours before scanning to enhance FDG uptake by the tumor and minimize cardiac uptake. Blood glucose level below 150 milligram per deciliter before injection of FDG to avoid competitive inhibition of FDG by glucose. Avoid muscular activity after injection to avoid physiological uptake of the muscle, and empty bladder prior to the examination. Injection and scan. After attaining the desired blood glucose level, tracer is injected according to the patient weight. An hour after administration of the tracer, whole body PET diagnostic single-phase contrast enhanced CT is performed. Coverage from the skull base to the mid-thigh, whole body PET without moving the patient. Then the whole study takes about 20 to 30 minutes. Post-processing data reconstructed in retrospect at different plans. PET data also reconstructed retrospectively at different plans, then fusion of CT and PET image for visual interpretation and measurement. PET examination were analyzed by qualitative visual assessment and semi-quantitative assessment. Cases: 48-year male patient complaining of difficulty of swallowing for hard and liquids. MEB image revealed normal physiological distribution of the tracer in the brain, myocardial region, renal collecting system, and the bladder, but there is increased FDG uptake at the region of the upper abdomen. Cross-sectional study showed increased FDG uptake at the fundus of the stomach and the cardia. Corresponding fusion image confirm the increased activity. Endoscopy confirm gastric adenocarcinoma. Second patient, 60-year-old female patient with gastric carcinoma, biopsy proven, and liver metastasis, received 6 cycles of chemotherapy for follow-up. Also, MEB image showed increased FDG uptake in the region of the upper abdomen, also the mediastinal region, bilateral supraclav, abdominal region. CT axial image, MEB PET image, and diffused PET-CT image confirm increased FDG uptake in fungating mass in the fundus of the stomach with increased uptake in the liver deposits. The same patient have multiple para-aortic lymph nodes, peripancreatic nodes, also increased activity in the peritoneum, bilateral supraclavicular lymph nodes with increased FDG uptake. The third patient, 42-year-old female patient complaining of generalized weakness and intermittent fever. CT image showed mass as a pylorus. PET confirmed increased FDG activity at the mass. Fused image showing increased activity at the pyloric mass. The same lesion. Hepatic focal lesion with increased activity. And peritoneal nodule at the pelvis with increased PET activity also. And the last case, 40-year-old male patient, not received treatment yet. CT showed circumferential thickening of the stomach that encroaching upon the lumen. PET image showed increased FDG activity at the mass, also at fused image with multiple abdominal lymphadenopathy involving most of the groups. Also posterior mediastinal lymphadenopathy, and coronal image revealed multiple abdominal and peritoneal lymph nodes. Also increased activity at the right thyroid incidentally detected nodule. MEB image confirm increased FDG uptake at multiple bony lesions. That's seen also at CT-based image. And PET image, fused image confirm that the increased activity is related to the bony lesion. So the primary result reveals that visual scoring shows that 66% of patients have FDG positive gastric lesion with average size of the primary tumor 57 millimeter. FDG uptake unrelated to gastric primary is also detected due to polyps and gastritis in some patients. FDG negative histologically proven lesion also detected in some patients due to mucinous adenocarcinoma. Nodal involvement detected in 20 patients with mean SUV max 4.3. 18 patients had distant metastasis with mean SUV max 4.6. PET-CT able to detect the metastasis. The most common site of metastasis is the liver, followed by peritoneum and bone, and lastly, muscle involvement. Overall, PET sensitivity was 85%. So, PET-CT is a feasible, comprehensive imaging modality for gastric cancer. It adds value to comprehensive imaging modality and may influence the management decision, but multicentric longitudinal study is recommended to figure out a unified criteria for PET interpretation in gastric cancer. Have time? Okay. And at last, I'd like to share with you a hint about the future of PET-CT, if you don't mind. Okay, so this scan showed dynamic PET scan, 18F-FDG PET-CT from injection. So, okay, This dynamic PET-CT from injection of the patient following the vascular phase, then stage of equilibrium, and at last, the last stage that we now detect at diagnosis. And the second case, لو صح؟ آخر حاجة، آخر سلايد. لا بعدها بس أنا عايزة أنا اللي أتحرك، يعني مش عايزة الفيديو يتحرك لوحده. مش عايزة الفيديو يتحرك لوحده، يعني أنا عايزة أنا اللي أتحكم فيه. عايزة تشوف البانل بتاعت الفيديو. يعني عايزة تشوف البانل بتاعت الفيديو، يعني خليه لا عايزة أشوف البانل اللي بتحرك عليها
لو خرجت كده أنت هتعرض هنا، مش هيبقى معروض للناس. كده عايز تشغل فيديو؟
عايزة أشغل الأول. اوكي كده ماشي.
اطلب منهم اذا كان في اسئله.
ماشي. وده التاني.
عندها مشكله.
And this gallium 68 Fabi from injection of the tracer, following the tracer till its accumulation in the case of cholangiocarcinoma. To have this dynamic study, we should have longitudinal axial field of view PET scanner. Total PET CT scanner is now available. It's a scanner that's able to scan the patient with one bed position, so we can decrease the dose of administered tracer. We can decrease the scanning time. We can have dynamic study. And I think it's promising because the most drawback of PET-CT is the higher dose of radiation and the use of radioactive material. So with this machine, with long axial field of view, we can reduce this weak point of PET-CT. And thank you.
Thank you very much, Dr. Ekhlas.
نفتح بقى بالنسبه للدiscussion.